Yes. Thank you very much, Chairperson, and thanks a lot, Ramesh, Dr. Sarath, and Dr. Deepak for inviting me. I'll be talking about dorsal root ganglion stimulation. Perhaps in the morning we had a speaker who talked about spinal cord stimulation, and I'm very happy to tell you that the first spinal cord stimulation in our country was done in this institute. I learned a lot from this institute, and that's why I'm taking it forward to the private sector. And that was 1998 when we did in one day we did 3 patients where we put in spinal cord stimulator, and from 1998 to 2005 we almost did 200 of neuromodulation devices. I'm still continuing in private sector. My last case was just about a month back, which we did in a patient of failed back surgery syndrome. So obviously, since morning, people have been talking about neuropathic pain, the various conservative therapies, but when everything else fails, see, basically these are not the first modalities. When all else fails, you have to rely on the neuromodulatory therapies. And initially, we had this spinal cord stimulator and intrathecal pumps, which we do in plenty for various pains like neuropathic pain, cancer pain. But then specifically, I'll be giving you an overview of dorsal root ganglion. Of course, spinal cord stimulation, everybody knows. Also termed as dorsal column stimulation. In the past, we had peripheral nerve stimulation, which came in a big way in the early 2000s, and people were putting leads everywhere, occipital nerve, anywhere where there was a pain or a scar, people put a lead and then connect it to a pulse generator. So that was peripheral nerve. But to be more specific and to address the focal neuropathic pain conditions, we have this modality which is called the dorsal root ganglion, and as the name suggests, you have to put the lead around the dorsal root ganglion. So this is what we used to do in the past. We put a lead in the spinal cord near the dorsal column, very close to the midline, and then fix it up and then connect it to a pulse generator. Initially, we do a trial for 4 or 5 days. If the patient has relief of more than 50%, then we put a pulse generator, and that's a complete spinal cord stimulator. But over the years, I think somebody was mentioning in the morning too, what my experience of almost 150 spinal cord stimulators is that over a period of 1 to 2 years, the efficacy of spinal cord stimulator starts going down, and sometimes patients are very upset about the paresthesias, and they say that I'm not happy. So I have explanted a lot of these stimulators because patients said that the efficacy has gone down, and that this is real. This may not be, you may not read this in the literature because the literature says that 3 months, 4 months, 6 months. Nobody does a 2 years, 5 years follow up of these patients. But most of my patients, almost 50% of my patients have said, no, I don't want it. Please take it out. This has happened. This is real. So then came the concept of dorsal root ganglion stimulation. Dr. Devesh was talking about dorsal root ganglion radiofrequency ablation, but we are talking about stimulation, which is more precise. And I'll tell you why we choose dorsal root ganglion. This is the dorsal root ganglion, and this is my lead, which is like just like spinal cord stimulation. This lead is around the dorsal root ganglion. Now, the difference between spinal cord stimulation and dorsal root, the anatomy of the dorsal root ganglion allows stimulation of abnormal pain fibers more selectively than the conventional spinal cord stimulation. So why we choose dorsal root ganglion, I'll come to it in the next few slides, but the literature in the last 10 years, maybe it came in 2009 probably, in the last 16 years have said that if it is a focal neuropathic pain like a post-herpetic neuralgia or a scar pain or knee pain, CRPS, phantom limb pain, dorsal root ganglion would be more effective than a spinal cord stimulator, and that's all. So this is the dorsal root ganglion we all know, and this is a very important structure which I just give you the anatomy. It's a nerve structure located in the intervertebral foramen, and the primary sensory neuron, these are the most important thing. It has a 15,000 primary sensory neurons, and we all know that the pathway of pain goes through these primary sensory neurons. So if you can do some modality which stimulates these primary sensory neurons, which are the cause of the neuropathic pain in a big way, then I think you have achieved good results. This is normal action persistence generated in response to sensory input, and they are carried through the propagation, and you have a normal sensory feedback. But in a patient with altered sensory pathway, there are inflammatory cytokinins which are released in response to the injury, spontaneous action potentials are generated by the cells in the dorsal root ganglion. And these are the primary sensory neurons where the action potential is generated. And if you can some way control these action potentials, you'll be able to control neuropathic pain much effectively as compared to what you do when you put it in the dorsal column stimulation. So it's a DRG is a very important, plays a very important role in modulating the sensory input. So there is a scientific reason why we do it, and it has been shown to be responsible for generating acute firing, as I said, increasing the possibility of neuropathic pain. So every target, like we burn the dorsal root ganglion in patient feedback, here we are stimulating the dorsal root ganglion to prevent the pain signals from traveling to the brain and in a way interrupt this pathway. Dorsal column stimulation, we still do not know. The spinal cord stimulation, we still do not know the hypothesis. It is maybe the paresthesia which cheats the brain sensation. So still till today, we are not sure how does spinal cord stimulation works. But herein, we have a hypothesis which says that primary sensory neurons are responsible, and we know it physiologically, and if you can work at that level, the thing would be much better. And this again to highlight that the action potential generation is reduced, and that's why neurostimulation techniques of the dorsal root ganglion have been able to, we don't have very much randomized controlled trials as yet, but whatever studies we have in the last 16 years, they have all shown to be positive results, and I think over the next few years we will be using this more often. So just to give you an example, focal neuropathic like a complex regional pain syndrome, we get plenty every day in our OPD, we get plenty of such patients. Post-hepatic neuralgia, one of the deadliest neuropathic pain conditions. If a patient comes after 6 months, you may do anything. I've put spinal cord stimulators, every devices I've done, and it's still a failure if it is more than 6 months. And then you see this is a patient who had a TKR or a surgery, and after that CRPS develops, and these are very common pain syndromes which come to us, and you have to do something. It's a localized pain. It's not a generalized pain, but it's a localized pain. So if you can localize the dorsal root ganglion and stimulate, patient would get much better relief in these patients. So these are some of the indications. CRPS, as I said, post-surgical groin pain, very, very common. Post-surgical knee and hip pain, TKRs, THRs, a lot of patients come with post-surgical foot and ankle, phantom limb pain, where nothing works. Even spinal cord stimulation doesn't work. Maybe dorsal root ganglion gives some hope. Fail back, I don't like this word. Post-surgery, continuous pain syndrome, peripheral nerve injuries, post-hepatic neuralgias. So this is as compared to the spinal cord stimulator lead. There's a difference. This is a lead which is little curved, and you can maneuver the lead. You can easily maneuver. Of course, the spinal cord stimulator, you can maneuver, only the tip moves here and there, but you can't sort of bend this portion is not like made like this, so you cannot bend. Because for enveloping the dorsal root ganglion, you have to have a lead which envelopes the dorsal root ganglion. And you can see you have to go through the epidural route, obviously. So if I have to put the lead on the dorsal root ganglion on the left side, I will have to go put my needle through the right, and it will be like a tangential insertion. So from here I'll put my epidural needle and just below the lamina here, and through that I'll put my lead and try to bend it, maneuver, because you have a sort of a stellate through which you can maneuver and keep it on the. You don't have to encircle the dorsal root ganglion, you can just keep it on the dorsal root ganglion, and the stimulation, when you do a trial stimulation, the patient would be able to tell you exactly the dermatomal distribution of the paresthesias which occur. This is again to show you, it's an oblique, it's a 14 gauge 2-gauge needle, and it's an oblique needle. If you're doing spinal cord stimulator, it's not difficult, because you have to go one and enter in below the lamina and then maneuver your needle into the around the dorsal root ganglion. So this is just maneuvering the needle around the dorsal root ganglion. This is again to show you that the needle, and through this we have put this. So we are going like this into the epidural space. This is my DRG lead, and my DRG lead I am trying to place it right on the dorsal root ganglion. So little difficult than spinal cord. Sometimes you get stuck in spinal cord stimulation lead also, but here you have to really use your expertise or maybe your luck that it may go there and lie on the dorsal root ganglion. So more efforts and more time are required. So this is again a lead on the dorsal root ganglion. So this is just to place just on the dorsal root ganglion, and once you do the stimulation, you will be able to. So there are different types of leads, like you have an octrode, you have a quadrotode, whatever, like 4 active leads or 8 active leads, which you can use, and then you can see as per the dermatome, you will get stimulation in that particular area. In spinal cord stimulator, you get a very wide area, like you can cover 80% of. So if it is a patient with a leg pain, I won't prefer a dorsal root ganglion. I would prefer a spinal cord stimulator. But if it is like a thigh pain or a knee pain or localized area pain, I would prefer this, because I'll be able to stimulate that particular dermatome where the pain arises, because I'm at that dorsal root ganglion and I'm doing it. The literature also says a lot about the lower extremity neuropathic pain syndrome. There are lots of evidences, and this is just a review which you can go through. And this review has mentioned about various studies which have found it to be useful in CRPS, in post-herpetic neuralgias, in failed back surgery syndromes, and in lots other conditions like a knee pain, lot other conditions. And one of the major difference between DRG stimulation and spinal cord stimulation is that the paresthesias are much better. As I said, one of my patients after the trial had a good relief, but he said that I cannot tolerate the paresthesia, because these paresthesias are really disturbing. I can't sleep. I said, you have good relief, so what about the pain which you had? But he said, no, I'm upset, I couldn't sleep the whole night. And he refused. After the trial, he said, no, take it out. So the advantage of DRG is that the paresthesias are much less. And you stimulate at sub-threshold levels, so that these paresthesias are hardly negligible or no paresthesia, yet the patient gets very good relief. So that's a bigger advantage over spinal cord stimulator, that you don't have paresthesias, which is normally seen a lot. Rather, we believe that the paresthesia is the one which distracts the mind of a person in spinal cord stimulation. But herein, you have less paresthesia or no paresthesia, and that's a big advantage of this. These are some of the studies which also found that 87% patients did not report any paresthesias. So to conclude, primary sensory neurons located in the dorsal root ganglion play a very important role in the development of chronic pain and maintenance of chronic pain. We all know that, but it has been substantiated now, and we know that it plays a very important role as a modulator of the sensory inputs, and stimulation can interrupt this process. Of course, radio frequency, as Devesh said, can cause damage to it, but why cause damage to important structure? Stimulate it. The primary sensory neurons are the ones which are taking the pulse impulses to the brain. You stop the impulses going to the brain, and the evidence is showing much better results than spinal cord stimulator. Little expensive, but even spinal cord is very expensive now for our Indian patients. So let's hope that in the future, dorsal root ganglion, particularly for focal neuropathic pain conditions, does a better job than anything else. Thank you. Thank you so much. Is there any questions we can take?
A question from the audience, please.
Yeah.
Thank you very much. Excellent talk. So we have in fact a huge number of DRG implants the last 15 years. The enthusiasm seems to have come down because the hardware is not very robust. There is a high incidence of fracture rate as well as lead migration. So in UK, pretty much most of them have kind of stopped doing DRG. They're all waiting for a new hardware to be released. So that the company has told us that it will be much more robust. There's a new sheath which would make it very easy to implant. So that's one thing. The second thing is, I mean, most spinal cord stimulators these days are paresthesia free. So
high frequency ones.
So burst stimulation, for example. Same thing with all the DRG stimulation. We do it paresthesia free because we use burst stimulation. The patients don't feel anything. But you're absolutely right that for focal neuropathic pain, and I've implanted from C5 to S1, pretty much every level I've implanted, and you get very good coverage of the pain areas compared to spinal cord stimulator if you have a very focal pain area. So again, I appreciate your.
Thank you. So actually in India, we get these products a little late, like spinal cord stimulation, the burst and the high frequency are still not available. So we run a little late than the world, but still, I mean, whatever we have, we continue to do the work.
So, sir, is it just one lead or you tend to, because most of the time it's overlapping pain and then you are not like specifically.
So, not generally one lead, but 2 leads minimum. But if it's a very, very local area, then 1 lead can also suffice. But it's generally 2. More than 2 would be very comprehensive. And these are very flimsy leads. These are very thin leads as compared to spinal cord, which are very good, hard and robust. They are very thin because you have to maneuver them. So as he rightly said, that the chances of the migration of the leads are very, very, very commonly seen. But the concept is good. And if we have a good hardware, I think the job would be done. Yeah.
Thank you, sir.